but I want to say that I'm very proud that I'm also an adjunct professor at Sun Yat-sen University Medical School under Professor Liang. And you might not realize it, but I am wearing my Sun Yat-sen Medical School tie. So although I'm in the other end of the world, I feel extremely close and feel very warm about my attachment to China and my position at Sun Yat-sen, and I want to thank you for inviting me. I'm going to talk to you about in vitro maturation, IVM, from a different point of view than you might normally hear it. And it's based on all of our work with in vitro gametogenesis. Now, I would start with the brilliant in vitro maturation Dr. Gilchrist asked a question to Hayashi in Hong Kong several years ago. He said, after 20 years of studies, I still have not been able to culture early oocytes to viable M2. How is this possible? Because Hayashi was able to actually make oocytes that resulted in baby mice from really in vitro gametogenesis from skin cells. And his answer is primordial follicles are locked by tissue pressure and by intranuclear location of the FOX3 gene. So you need to isolate and stop nuclear rotation in order to do that. And it's very, very difficult. But to try to culture from the primordial follicles is an enormous undertaking. But you're going to see now in this lecture, it's very easy to get competent oocytes from the ovary just by going to the GVs that you find in the medulla and the medullary cortical junction. So you all know the primordial follicles are all located in the cortex. And when we do ovary tissue freezing to preserve fertility for cancer patients, we just freeze that cortex. But we're missing out on the developing follicles, which now we know in vitro we can mature and get as many high quality M2s as you could if you did ovarian stimulation, but you don't have to do ovarian stimulation. So the evolution of clinically simple IVM works like this. Now, it began a long time ago with efforts by Epic and Woodruff and Shea and Telfer and Albertini and Gilchrist and Smith, many others, trying to culture these resting oocytes of the primordial follicles for cancer cases. But Hayashi compared those primordial follicles in ovarian tissue to in vitro iPS cell-derived oocytes and found that primordial follicles are locked. And frankly, with endangered species and biologists that want to preserve them, he said and shocked everyone that he would rather have skin than ovarian tissue. And in order to understand why IVM works, you really must understand in vitro gametogenesis. And IVM should be a routine, everyday procedure for ovarian tissue preservation. So my work began with Dr. Hayashi on this issue about 6 years ago. And I just make this funny, humorous slide. Usually the Japanese tend to be shorter and the Americans tend to be taller. But in this case, Dr. Hayashi is almost twice as tall as me. So we call him the X chromosome and me the Y chromosome. It's just a joke. But to understand IVM, you have to differentiate between these three phases of in vitro gametogenesis. IVD, and that's really where you're actually taking PGCs and turning them into secondary follicles. That's done by fetal granulosa cells. There is no special culturing technique involved except that you let fetal granulosa cells do their job, and just like in the early fetus, convert PGCs into secondary follicles. Then the next stage of in vitro gametogenesis is what we call IVG. And that's where you just incubate these secondary follicles that are just beginning to be sensitive to gonadotropin, incubate them with FSH for 11 to 14 days. And then the final stage is IVM, and IVM is only a day or two at most. Because once that GV has been prepared with meiotic competence by the FSH, it's ready to be matured very easily and very quickly with HCG. Let's explain that again in a different way. In vivo-derived primordial follicles are locked, but in vitro-derived oocytes continue meiosis automatically. and then they promptly die if they're not fertilized. So let's take a look at Hayashi's original diagram from his publication with Hikabi and his own publication later in Nature and Nature Protocols. You can see, if you look at carefully, that there are the stages of IVD, IVG, and IVM. With IVD, we're incubating just these PGCs derived from IPS cells, derived from skin cells. We're just incubating them with fetal granulosa cells. And then after 21 days of that, we incubate these secondary follicles that have formed with FSH. Now, that makes them meiotically competent. Once they've had that 11 to 14 days of exposure to FSH, they are ready to be very quickly in vitro matured with HCG. And let's go through this again in a different way. You can see that PGC specification occurs very early. In the human, about at 10 days. These are early amphiblast cells that are separated from the rest of the developing embryo. And in vitro gametogenesis just copies this fetal process. And so actually, if we make oocytes from in vitro gametogenesis, they'll be very young oocytes because we're just recapitulating fetal formation of oocytes. And I'll show you this in this diagram again so you'll understand in vivo on top. You can take ICM cells and they go into blastocysts normally, and those blastocysts then result in PGCs. In vitro, you can make embryonic stem cells by induction with these genes, and these PGCs can be made by 5 different genes with epiblast-like cells. So you're just repeating in vitro what happens normally in the early fetus. And this, again, you can see we have with PGC-like cells, and we mean like cells because they come from IPS cells derived from skin. They're not embryonic stem cells, they're IPS cells. And you incubate them with fetal gonadoc somatic cells, and 3 weeks later, at least in the mouse, lo and behold, you have a reconstituted ovary with secondary follicles. So an outline of making an oocyte in vitro is as follows. Skin cells are converted to IPS cells in 3 to 4 weeks, IPS cells to epiblast cells in 2 days, epiblast-like cells to PGC-like cells in 6 days, and PGC-like cells with granulosa cells, an aggregate for 3 weeks. So this is where I'm going to stop and make you think that these are fetal granulosa cells. It won't work with adult granulosa cells. You're just recapitulating fetal development of oocytes. And this is called IVD, or in vitro differentiation of oocytes. And that's already happened, really, in the ovary tissue. And then the FSH culture occurs after 11 days after association, and that's IVG. That is in vitro gonadal sensitivity. And that's when the secondary follicles are prepared for meiotic competence. And then just HCG culture, for 1 day, is IVM, results in the mature oocytes. So let's go over the dynamics of oocytes in the ovary for a minute. Oocytes in the human ovary, about 4.5 months after recruitment from primordial follicles, have already completed IVD and IVG, and they're ready for IVM. This is a constantly changing daily dynamic. Oocytes that were recruited less than 4.5 months after recruitment from primordial are going through either early IVD or later IVG. In vivo, once the oocytes have completed IVG, they are meiotically competent and ready for HCG or the LH surge. This is a constant daily process. At any time, a certain number of oocytes in the in vivo ovary have completed IVG because they're exposed to FSH all the time, and they're ready for IVM. That is the completion of meiosis to metaphase 2. So there are always a certain number of oocytes in this dynamic process in the in vivo ovary that have had their exposure to FSH and are ready for meiosis to be completed. Now, IVM works because the in vivo ovary is constantly preparing oocytes for it. The GVs that became gonadotropin sensitive are the ones we get with ovarian stimulation. That's true, but you don't need ovarian stimulation. New GVs are appearing daily after finishing IVD and are gonadotropin sensitive, and then they begin their IVG. You don't have to give them gonadotropin. They're exposed to it already in vivo. Mature GVs that have finished IVG and are not ovulated or matured by IVM or fertilized will die. Now, in an ovulatory cycle where one lead follicle becomes dominant, the non-dominant follicles still are going through IVG, and they attain meiotic competence, even though they're not dominant. So I'm going to go a little bit more over in vitro gametogenesis, but I want you to understand that there is no purpose to the ovulatory cycle, to the cyclic 28-day hormonal cycle, other than to create Graafian follicles that are able to ovulate or that we can aspirate with a needle. But this cyclic production of Graafian follicles is absolutely unnecessary when it comes to making these secondary follicles meiotically competent. So here are a group of PGCs and fetal granulosa cells in the mouse, and we separate them off so that they can be exposed to culture media and not to high pressure. This is Dr. Hayashi doing that with a tungsten needle. And after we separate them off and culture them for 3 days as single follicles, you can see that they will turn into secondary isolated follicles. And then after IVG, they turn into meiotically competent GVs. So, relation of Hayashi's success with in vitro gametogenesis to clinical IVM tells us why IVM should be so simple. We overcomplicated it. During the first 3 weeks of culture of PGCs and fetal granulosa cells, this is IVD, so no FSH because it's not FSH sensitive. You dissociate and open the secondary follicles for IVG with FSH, and then you culture them for 11 to 14 days. You keep the cumulus open for IVM culture. And some of the questions is, what is the concentration of FSH you need for IVG? Or the concentration of HCG you need for IVM? This is a drawing Hayashi drew on the blackboard of just how when you do this in vitro, these eggs just come up on a stalk like they normally would in a Graafian follicle. And here they are developing into from secondary follicles into GVs that are ready for IVM, and the IVM occurs very quickly. And then these are the first iPS cell-derived mouse pups that came from the skin fibroblasts of their mother. So then Klaus Anderson really opened this up clinically a lot just in February of this year when he pointed out what we all should realize. GVs derived from the ovarian medulla during dissection of the cortex for ovarian tissue freezing can be cultured to a surprisingly large number of competent M2s, which then can be vitrified. He likes dissection at room temperature. It's slightly better on ice. We haven't found a huge difference. And the standard way that people concentrate FSH and HCG for IVM is 75 milli-IU of FSH per milliliter and 100 milli-IU per milliliter of HCG. But this is not absolute, and we've done it every which way, and we found out that it really doesn't matter what concentration or FSH or LH you use. You don't need IVM media. It's an automatic process, and I'll explain that. When you understand the physiology of the ovary, you'll understand this better. Now, we don't remove the cumulus, but it may not be 100% correct because we've all demonstrated, Hayashi's demonstrated, the cumulus isn't absolutely essential to have maturation to M2, but it is very supportive and it makes it work more effectively and more efficiently. But even without cumulus, you can get maturation to M2 in vitro. Now, Klaus then did something very spectacular. He did next generation sequencing of 53 of these M2 oocytes, and their first polar bodies, and 64% were euploid. The M2 rate was 1 in 3, resulting in a total number of M2 oocytes that was similar to the number obtained after ovarian stimulation. So what does that mean? That means that if a young woman has cancer, we can just take out her ovary or one of her ovaries right away. Of course, freeze the ovary tissue, but we can also get enough mature oocytes for eventual IVF so that she never needs to have or bother with ovarian stimulation. We can get the M2 oocytes from IVM. And it sounds remarkable, but it's amazingly simple, and I'll explain that to you. Now, the advantage, of course, of using the whole ovary is these small antral follicles in the medulla may span diameters ranging from a very small 1 millimeter to up to 10 millimeters, and most of them, you can't really aspirate with a needle. Increasing the number of immature oocytes is collected from surplus tissue, and the nuclear maturation rate, the meiotic competence, has already been established by normal in vivo FSH over the previous 11 to 14 days and by IVD over the previous 4.5 months. And the interesting thing is the aneuploidy rate from these many matured M2 oocytes, 36%, is no different than in vivo matured from a standard IVF stimulation cycle. So the cumulus is not essential after IVG, but it is just supportive, and we didn't realize that before Hayashi's work. Don't use a cortical slicer for vitrifying the tissue. Just dissect the medulla off very thin, because if you use a cortical slicer, you're going to lose those GVs. Just ordinary culture media, IVM media, equally okay. And the standard concentration of FSH is 75 milli-IU per milliliter and 100 of LH, but in truth, it doesn't really matter, and I'll explain that to you in a minute. It works because many GVs inside the medulla have adequate time of exposure in vivo to FSH. That is because there are so many of them. 1,000 per month were recruited from primordial follicles 4 months earlier. It is so easy to collect many GVs from these tiny follicles by having the ovary in hand instead of using a needle. And it's not unreasonable to expect that up to 30 GVs every day will have already had adequate in vivo exposure to FSH. So we know that 30% of GVs that we get from this tissue already have been meiotically made competent from in vivo exposure to FSH for 10 to 14 days. So why do we even need ovarian stimulation? And why do we even need the normal ovulatory cycle? We don't need ovarian stimulation for oocyte maturity. FSH has already created GVs with meiotic competence. You do not even need the normal ovulatory cycle for meiotic competence of GVs. You only need ovarian stimulation or the ovulatory hormonal cycle for follicle enlargement and either normal monoovulation or for oocyte retrieval. Otherwise, you don't need this whole complicated system other than to get the oocytes out, but you certainly don't need it for maturing oocytes. So we have widely varying IVM media results, and we want to explain that in a minute. And the rest of my talk is kind of limited to another 10 minutes, but these are the main points, and that is that whether we use as little as 10 milli-IU of HCG to 1,000 milli-IU of HCG. And Hayashi uses 1,000. 10 is considered by everybody, not enough. And we get a 32.3% metaphase 2 rate with even using cleavage media, not even using IVM media. Klaus Anderson, using the standard 75 and 100 milli-IUs, gets 31%. Seegers in Brussels, who've got a great program with IVM, they use the standard FSH and 100 milli-IU of HCG, and they get 39%. Hayashi, with his protocol, gets 30%. So it seems like there is kind of an intrinsic, invariable limit. And there are some patients you may only get 9% maturation, and some patients 60%. But in a large group, it always comes to 30%. So Anderson points out you get as many M2s, average 13, with ovarian tissue IVM as with hyperstimulation. And I'm going to postulate that IVM success is intrinsic to removal of the meiotically prepared GV oocyte from the ovary itself, and not to the specifics of the culture media. Now, we know these oocytes lead to pregnancy in babies. We've known that since 2014 with the paper by Prasad and Shia. And we've known that from Seeger's work in 2015 from Brussels, and from Uzelac in 2015 from Kentucky, and then from Seeger's again just this year, reporting the first live birth following the use of just oocyte vitrification from ovarian tissue. So we know these are healthy eggs, and Klaus Anderson showed that they are euploid just as much as with ovarian stimulation. So these are good quality eggs you get without ovarian stimulation. So now in the few remaining minutes, you want to know how we do it. Well, simple. Here's the ovary. It's been removed. It's in a petri dish with any kind of media you want. It really doesn't matter. And we do not discard the media because that's where the GVs are located. Now, Anderson shows he prefers doing the dissection at room temperature or warm, not over ice. But, I think if you haven't had the ovary traveling for 24 hours on ice, we found that whether on ice or not, when you do the dissection, really doesn't make a big difference. And we dissect out the medulla. I wanted to show you some videos of this, but we couldn't upload them. The files are too large. I can certainly send them to anyone, but you can still get the idea. We do the dissection and get down to the bare cortex, and we make it so thin that we know that that's the tissue that we're going to vitrify. And we cut it up into little pieces for vitrification, which would be a totally different talk than I'm happy to give any time to my colleagues here in China. But this talk is just about IVM. So, of course, we vitrify the tissue, but then in addition, after we get the tissue ready to be vitrified, we look at the media. And when we look at the media, we find all these GVs. Now, you can see in all this material in the dissection media, in a very tiny little spot in the dissecting microscope, which happens to be the oocyte. And it's a GV with a bit of a corona around it. And you just have to look for these and not just throw away this media, and you can get huge numbers. So I'll give you an example. I'll give you many examples. Here's a 27-year-old woman with B-cell lymphoma of the cervix. She had no prior chemotherapy. If they've had prior chemotherapy, that really ruins your chance for GV maturation with IVM. You can only then rely on ovary tissue freezing. But we had 21 pieces of ovarian tissue, so we can transplant that back in the future, and that should work fine. But we also will have enough eggs that we can do IVF. So we just use Menopure, which is nothing, 75 milli-IUs per ml of FSH and LH, and that's the equivalent of just 10 of HCG, really. Menopure doesn't really tell the truth about their LH content. It's really 10 IU of HCG. So it's a tiny amount of HCG, and we use ordinary cleavage media. And 24 to 44 hours, we had 12 M2s from 22 cumulus complexes, or 40% IVM rate. And nothing special was done. Here are the many GVs you put together from the medullary dissection. Here you can see just the tissue. When we look at the ovarian tissue that we've frozen, you can see the GVs that were still in the tissue. And then 2 days later, we have beautiful M2 oocytes that are quite competent, just as though you had done ovarian stimulation, but you didn't have to do ovarian stimulation. And the reason you didn't have to is look at all those beautiful M2s. The reason you didn't have to is because that ovary has been exposed to FSH already. And 30% of those GVs you get are going to already be meiotically competent, and they don't need ovarian stimulation. Now, here's a 39-year-old who wanted to freeze her ovary tissue just for social reasons. Very low ovarian reserve. We used ordinary cleavage media, just the 70 milli IU per ml of Menopure. All she had was 3 cumulus complexes, but we were able to get 2 good quality M2s to vitrify from that. You can see how few her primordial follicles are. And you can see she has good GVs nonetheless, and there we get M2s from that. Here's an example 3, a 14-year-old with Ewing sarcoma. We really don't want to stimulate her anyway to get eggs, so we freeze the ovary tissue. But once again, cleavage media, 150 milli-IU per milliliters of Menopure, which is nothing. It's like 20 milli-IU of HCG which the ideal would be 100. And yet with this tiny amount of HCG, we get 40% maturation, 13 good quality M2 oocytes from 34 cumulus complexes. Many primordial follicles in the ovary slices. You can see them developing into beautiful secondary follicles, but do not just freeze the ovary cortex. Also, many GVs are found on dissection. Here's her example, 14-year-old, and we have these good GVs. And then on day 2, many good quality M2 oocytes and a 14-year-old who never had to undergo stimulation. Here is a adult, a 30-year-old, and her reason to freeze is she has a daughter with Turner syndrome. And she had her ovary tissue removed for vitrification for eventual transplantation. But ideally, her daughter should have IVF from this. And again, we just use ordinary cleavage media and 75 milli-IU of Menopure, and we got 42% maturation rate or 10 good quality metaphase 2 oocytes. There you can see her cortex tissue, which we can transplant, but there's her metaphase 2 oocytes. So here's just another example, but this one is an interesting one. We knew that we could remove the cumulus early because the cumulus isn't absolutely critical for M2 IVM. However, it's very supportive. And we removed the cumulus, and it was probably a mistake, and we got 5 M2s, only 19%. So there's two interesting things. One is that we actually got M2s without any cumulus. And the other interesting thing is that we had a lower maturation rate than if we leave the cumulus on. So day 0, you see all these beautiful GV oocytes. We cleaned the cumulus off early. Bad idea. And we only got 5 oocytes that were any good. Here's a 6th example. This time we used actual IVM media with the standard concentration of Menopure and HCG. And from 14 cumulus complexes, we got 36% maturation. You can see the tissue, and you can see the mature oocytes. Finally, I'll show you another sample because I'm running near the end of my talk. And we got 20 pieces of ovary tissue from this 14-year-old girl with a nodular sclerosis Hodgkin's lymphoma. And again, we used IVM media with the standard concentration of Menopure and 100 of HCG, what everybody recommends. And we got 38% M2s, or 14 M2s. So in every case, we got as many M2s as we would have obtained if we had done ovarian stimulation. And you can see that it doesn't really matter what kind of media you use, though I do recommend you keep the cumulus on. Here you can see how the oocyte is beginning to mature on its own, really in the ovary tissue without having had any exposure yet to HCG. So the exposure to FSH and making it meiotically competent means the cumulus cells really aren't so important anymore. They're helpful, they're supportive, but they're not absolutely totally essential. So there you can see all these GV oocytes. And on day 2, we have beautiful metaphase 2 oocytes. So why do we need ovarian stimulation? I'm just going to repeat this. We do not need ovarian stimulation for oocyte maturity. FSH has already created GVs with meiotic competence. We do not even need the normal ovulatory cycle for meiotic competence. We only need ovarian stimulation or the ovulatory hormonal cycle for follicle enlargement and either monoovulation or oocyte retrieval. There are many GVs inside the medulla, and there are so many of them, 1,000 per month were recruited from primordial follicles 4 months ago, that it's so easy to collect 30 or 40 or sometimes 100 GVs from these tiny follicles and get a 30 to 40% overall meiotic competence, and it appears to me it's universal no matter what kind of media you use. So this is just a repetition of sample 1 that reminds me my 30 minutes are up. And I want to, again, thank my colleagues at Sun Yat-sen. I've learned so much from Dr. Liang and Dr. Liu and andrology and all the many others. I've even got an office there. I'm very, very proud of my association with China. I'm embarrassed that I don't seem to have the time to really learn either Mandarin or Cantonese the way I should. But luckily, they struggle with me with my English. And I'm so sorry that the COVID problem has kept us from being together like we always are, at least twice or three times a year. And I look forward to when all this COVID thing is over and we can again do our beautiful collaboration. And I'm very proud of this Sun Yat-sen tie that Dr. Ping Lan gave me when I first became a adjunct full professor. So thank you very much from St. Louis, from the other side of the world, and I send my love and all my best wishes to my colleagues and friends in China. Bye-bye.